Hello? Okay. Hello. I think we're going to get started with our next panel. So those of you who are already in this room know me, but my name's Margaret. I'm a genetic counselor working at Boston Children's Hospital. I primarily work in research on rare diseases and their therapeutics. And we'll be talking today a little bit about just like the basics of genetics and try and see if we can't answer some of the questions that have been rolling around today. And I'll have my other panelists introduce themselves as well.
Hello, my name's Alaina Acchione. I'm also a genetic counselor, and I'm a genetic counselor at Krieger in our Batten disease clinic.
Hi, everybody. I'm Dr. Amy Brower, and I'm a medical geneticist. I'm a professor just up the road at Creighton University and the University of Nebraska Medical Center. So excited to be here today.
All right. So we're just going to get, we'll see if this works. Use the clicker? I am using the clicker. That's okay, I'll just do this. Cool. Okay. So we're going to start off with just some basics of genetics. And I'm sure a lot of you have heard bits and pieces or all of this information before, but oftentimes it might get lost in the haze of doctor's appointments or other settings where there's many, many other things to focus on. And so we thought we'd just start with a little bit of a review. So we all have roughly 20,000 genes in our body. We get half of them from our mom and so there's 2 copies of every gene, one from mom and one from dad. And I heard there's trivia tonight. So fun fact, if you took all of the genetic material in your body and put it in a long, long string, it would travel from the sun to Neptune and back 4 times. So it is a ton of genetic information that we're all walking around with. Our genes are made up of DNA, and they give the instructions for our cells to grow, develop, build our body, and perform all of the functions that it does to keep us alive. Some of these genes are associated with our health and with known genetic conditions or diseases, but others we either don't know about yet or are all just contributing to the ways that we're different, we look different, our general backgrounds, and so there's many, many different associations between genes and health and how our bodies work. So essentially DNA is made up of 4 letters, A's, G's, C's, and T's, that are strung together, kind of like a code book. So they spell out the instructions exactly like you were reading through an instruction manual per se. That DNA is then organized into genes. If we're going with this analogy, we can think about our genes as being the sentences within that code book. Each sentence has spaces and letters that form a message that give a certain instruction or tell our bodies what to do in a specific way. Because we have so many of those genes, they have to be packaged really, really tightly, and so it gets packaged in these things called chromosomes. We all have 23 copies, and there are different genes on each chromosome. And then all of those chromosomes get shoved together in every single cell in our body. So there's tons and tons of genetic information. And so how do those instructions actually turn into something that's doing work in our body? So if we're starting with DNA, that gets translated into RNA, which is essentially a single-stranded version. If we're thinking about DNA as being some large code book, I would think of RNA as being like an order form. It's writing out all the orders for what we need in our bodies that then get turned into proteins. And proteins are what makes up all the structures in our body, do all the actions. There's enzymes that are processing things within our body. They have all sorts of tasks that they have to do. So what happens when there's a change in that code book? Genetic variants are changes in the spelling of a gene, and it can have an impact on how the gene functions or its ability to make the protein that it codes for. And there's many different types of genetic changes. There's chromosome abnormalities, so like trisomy 21, you can have more or less of the chromosomes. You can have structural variants, so inversions and deletions and duplications where things are kind of not in the order or turned around. You can have copy number variants, which is just a loss or gain of extra genetic material. And then also single nucleotide changes, where just one single letter or a few letters get changed for another group, thereby changing the meaning of the sentence. So if it's originally the sentence was the cat jumps over the log, but now the C is a B, and so it's the bat jumps over the log, and that doesn't make any sense anymore. We also, there's a number of ways that those genetic changes can get passed down or inherited. There's kind of two that we see in Batten disease, the first being autosomal recessive. This is most of the Batten diseases are autosomal recessive, in which both copies of the gene need to have a genetic variant in them in order for the disease to manifest. So often the parents are carriers. They each have one genetic change but have no symptoms because they just have one genetic change. And then there's a 1 in 4 chance of passing that condition down onto a child when the right combination occurs. There is one form of Batten disease, CLN4, that is an autosomal dominant condition. And what that is when you just need one copy of the gene to have a genetic change in it for it to cause disease. And so in that case, the child of an affected parent has a 50% chance of also having that condition. CLN4 is an adult onset condition, so often people don't know that they have this before they have children. Typically in autosomal dominant conditions, there's a significant portion of those that are random or de novo, happening new in a person. They're not inherited at all. They just arise in a person for the first time. And with that, I'm going to pass it over.
All right, so now that we have a good background of genetics and how, what's going on in our DNA, I wanted to just share a little bit about, well, what is a genetic counselor and what kind of role do we have for someone who maybe already has a diagnosis? So the biggest thing that most people think about is we often are coordinating genetic testing and also interpreting the results. So if you are ordering testing or you want results, you usually have to meet with a genetic counselor. But we often can provide emotional support through a diagnosis. So that could be education on the diagnosis, supporting decision-making for testing other relatives, so maybe younger siblings or cousins or aunts and uncles. We can help with coordinating that kind of testing. And then Margaret is a really great example of getting involved with research that can often be done through a genetic counselor. And so I just wanted to put this up here so that we have it, that there are all the different subtypes of Batten disease, and it's really dependent on the gene that has the change. So we've talked a lot about how clinically there's a lot of overlap, but when we think about the different subtypes, it's really due to what gene is affected and then what protein is affected. And so that's how we get to the root cause of which subtype of Batten disease someone has. So what I'm going to do now is just talk a little bit about the different types of genetic testing that people may get to a diagnosis of Batten disease, and go through the differences of when you would use one or the other. So some people have single gene testing. So out of the 20,000 genes, we're testing one single gene. And this is really useful if we know exactly what we're looking for. So if maybe there's already a diagnosis in the family, or we're very suspicious about one specific condition, we would order single gene testing. We can also do a panel test, and that's looking at a set number of genes. So it could be 10, 50, hundreds of genes, and there's usually something in common for all of those genes. It could be all of these genes are associated with seizures or maybe vision loss, so it's very targeted to maybe a specific symptom. And then lastly, a lot of people will get something called whole exome or whole genome sequencing, and this is where we're testing all 20,000 genes in the body. So we're looking at all of the DNA for anything that could be associated with any of the symptoms that the person has. So usually, if you want to go super broad, exome and genome is the way to go. So to talk a little bit specifically about cascade testing, this is often a single gene test, and it's most used when we're testing an at-risk relative for a known variant or variants that are in the family. So one example, so this is just a made-up story, but if, let's say Johnny's 13, he has Batten disease, but his younger sister's 6, and his parents are interested in getting his sister tested, we would test his sister specifically for the variants that Johnny has, and that would be considered cascade testing. Another example was, let's say Johnny's mother, she's a known carrier, but her sister wants to know, well, am I a carrier too? we could do testing for her, and this would also be cascade testing. The next kind of testing is called carrier screening, and I think earlier someone was asking a little bit about, well, how can we know what's someone's chance of having a child with Batten disease before we even know about it? And carrier screening is often used. So the purpose of carrier screening is to see what conditions am I a carrier for. And so Batten disease would be one of those that's often tested for on carrier screening panels. So just like Margaret had said, carriers are typically unaffected, but if two people who are both carriers have a child together, there's a 25% chance of having a child with that condition. And so some people, often before pregnancy or maybe during pregnancy, they could get carrier screening panels done where they look at a set number of genes that we're testing to see are both mom and dad both carriers for the same condition or not. And this way we could get an idea of, okay, is there actually a risk for a certain genetic condition? Oh, and I just want to add, we are all carriers for conditions. We just don't know it until we do testing or have a child with a specific condition. So again, this is really helpful to inform family planning or medical anticipation, understanding kind of what to expect, or guiding future genetic testing. And it's often done before pregnancy. This is just a sample of a carrier screening report, and you can see this person, it's actually a fake report, but they use CLN3 as the example. So this is just a sample to show what a carrier screening report could look like. So I'm going to get into the weeds a little bit of how to read a genetic test report. And the reason this is helpful is because there can be research opportunities, and people may ask, well, what kind of variant does your child have? Or, my child has this variant, what is your child's variant? So we'll go through exactly how to understand that and what to take out of a genetic test report. So to go over some terms, the gene name is very important. So we want to know what is the gene name so we have an understanding of what condition are we talking about. We also want to know, well, what is the specific change in the DNA? What is the variant? And then we also want to know, what is the variant classification? There's a wide range, but variants range from benign or not harmful, doesn't cause any problems. There's the VUS, which some of you maybe have had to deal with, this level of uncertainty. Well, what does this actually mean? How can we figure it out? All the way to pathogenic, where we know for sure that this is causing problems. And then we have the C dot and the P dot. So this is where it gets a little confusing. So the C dot tells us where exactly in the DNA is this spelling change, and what is that spelling change? And the P dot tells us, well, what is the impact on the protein? So we have this example here. Nucleotides are just the letters in the DNA, and then the amino acids are the pieces of the protein that come together. So as you can see, at nucleotide number 11, there's supposed to be an A, but in the bottom row, it turned into a C. So we would say for this variant, it would be C dot 11, A to C. And then P dot, it's supposed to be a histine, so H-I-S, at number 4, and it turns into a proline, or P-R-O. So that's why it would be P dot his for pro. So that's how we understand what is the exact variant. Inheritance, I think we've talked about this a little bit. Something can be maternally inherited, paternally inherited, or brand new in the child, so de novo. And then zygosity is just a way that we can tell, is it present on one copy of the gene or both copies? So heterozygous means it's only on one copy, and homozygous means it's present on both copies. So I have a sample genetic test report that we can kind of walk through and go over exactly what it means. So the first thing we can see is the test that was done. So this was a retinal disorders panel. So it looked at 330 genes that we know impact the retina and vision. So this child had testing for only vision loss. We can look at what genes had variants in it. We can see exactly, well, what are those variants? Is it present on one or both copies? And what is the classification? So for this very first variant, we know it's in the PPT1 gene. And at nucleotide number 287, there's supposed to be a G, and the amino acid is supposed to be a cysteine. But with this specific variant, that G turns into an A, and it produces tyrosine instead. And so the way the variant is written is 287G to A, and then cysteine 96 to tyrosine. And so that's how we know exactly what is going on in the DNA. Heterozygous, it's only present on one copy. And then likely pathogenic means, we're fairly certain that this impacts how the protein would function and would be considered disease-causing. The second variant is a little bit trickier because it's classified as uncertain. So in our DNA, we have something called exons and introns. Introns get cut out and are not included in the protein, and then the exons get all clumped together to produce the protein. So sometimes you may get a variant that says intronic, and that means that the spelling change is actually in the intron that typically gets cut out. And so how we read this is number 362 is the end of an exon, and we go 5 letters past that, it's supposed to be a G, but then in this patient, it's actually an A. But we don't know, does this actually cause any problems to the protein or not? So for this specific patient, we had to do enzyme testing to confirm, and it actually is pathogenic, so we've gotten this variant upgraded. But if someone does have an uncertain result, you can always ask, what are follow-up testing that we can do to confirm if this is pathogenic or benign. So there's often testing we can do to figure that out. And then this one is actually the most common variant in CLN3 disease. So it's actually a deletion of 2 exons. So we have exon 7, 8, 9, 10. Exons 8 and 9 are deleted. And so now we're missing part of the protein. And so we know for sure that this is pathogenic. It causes problems. And it's homozygous, which means it's present on both copies of the gene. Okay, and I'll pass it back to Margaret.
So now we've gotten our testing result back, and I think the biggest question that I think we've seen in the clinic space is, okay, so what do I do with that? And so we've heard from a lot of experts today, and so I think some of this might be new, some of it probably isn't, but I just thought to go through the first step would be to assemble your team. And I think the biggest thing here is that the people that you have on your team are going to look slightly different based off of the needs of your child. And that team might change over time. So you might not need the support of a dietitian when you first get your diagnosis, but maybe that's going to be something that's super helpful later on. Or maybe you don't really need a speech therapist right now. But it's good to know what your resources are and who's available and what your team can look like. And so in this graphic here, I have kind of the different elements of the current Center of Excellence core services for the BDSRA. There are also individuals outside of this kind of graph that you could enlist to be part of your team, but the key players are going to be neurology, who can help with things like EEGs, medical management, assessments. They might also often be your research connection or know about clinical trials that are ongoing. Your ophthalmology team does the same for the eyes. PT, OT, and speech can be really helpful for the prevention or preservation of skills, assessment of mobility, aid need, things like that. Genetics is really helpful at the very beginning of your journey to kind of get those referrals going, and are always available kind of in your back pocket, especially for cascade testing like we mentioned, or to go back and answer questions or revisit every once in a while. And then social workers and psychology is also really helpful for all family members as just a tool to help you through this journey. I also wanted to talk about genetically targeted therapies because that is another one of the most commonly asked questions is there a therapy? And I'm involved in a lot of research around genetic therapies. So there are more than this list, but these are kind of the 4 main types of therapeutics or therapies that I get asked about. So enzyme replacement therapy is a type of therapy that directly replaces an enzyme that is missing. So an example of this is Brineura. An antisense oligonucleotide works to impact the RNA level. I describe it as like a Band-Aid. It covers up kind of a mistake in that code and helps the cells kind of read over it. Melicin, which was a single patient initiative, was an example of that. Spinraza is a much bigger version of that for spinal muscular atrophy. There's gene replacement therapies, which use viral vectors to introduce a new working copy of the gene. There's investigational therapies for CLN6, and we heard about a bunch of other versions of this today. And then gene editing therapy is a new one. I get a lot of questions in my research role about this right now because it recently rolled out for metabolic conditions at Children's Hospital of Pennsylvania. And this acts like a cut and paste mechanism to directly address genetic variants by changing it directly in the genome. And it is not currently available for neurologic conditions because we don't yet have a way to get it to the brain, although people are working on it. I did also want to talk a little bit about the different types of research that you could be enrolled in. And one of the things that I did was, I think when you scan the QR code to, we don't have it up, but at some point there will be a QR code to a Google Doc, but I created a little bit of a list of how to get involved in research if it's something that you're interested in. Different places that you could go to look for what's available right now, but also some educational resources about what does research even mean or look like. So there's a few different types. The first is basic science. This typically is lab bench work that's used to better understand Batten disease and how it impacts the body. Your participation in benchwork science might be donating some blood or donating a skin sample or donating some DNA, but that's typically what that looks like. Natural history studies, we've heard a lot about them today. They track individuals over time to understand symptoms and disease progression, and they often provide a really good baseline for therapeutic trials later down the road. Clinical trials often will include testing a new drug to see if it helps with various symptoms or other endpoints. And then social and emotional studies are one that might not be immediately top of mind, but there are a category of research that goes on to better understand people's experiences with rare disease or a specific condition or just interactions with healthcare in general in an attempt to make those experiences better or to better understand how we can be supportive. So those are kind of the different types of research that you might get involved in. And I think with that, we're going to transition to a little information about newborn screening.
Thank you. Hi, everybody, again. What a great tag team, you guys. This was awesome start out. So thank you so much, everybody, for the opportunity to present to you today. So today we're going to explore a little bit about the background of newborn screening and talk a little bit about the future of newborn screening. One of our goals in newborn screening and genetics is that someday it will impact lives like yours and all the diseases that we all struggle with and that we all have challenges with. So let's get started. So advancements in technologies to screen, diagnose, treat, and manage disease are really at the forefront of the newborn screening system. We call it a system in the United States and around the world because it's really meant to be more than just screening. It's really to enable the early identification and hopefully someday the pre-symptomatic diagnosis with the opportunity, this really crucial window of opportunity to intervene so that we can have meaningful change in these lives. In the United States, there's a wealth of federal initiatives that have been supporting newborn screening for the last 60 years, and we've seen some changes on the horizon, especially this year, and I'll touch on those at the end of my talk. For over 60 years in the United States, newborn screening has enabled this early identification of diseases. Today, molecularly designed therapies, like you just heard about, are really revolutionizing newborn screening and opening up the possibility of screening for not just tens of conditions, but maybe someday thousands of conditions in the neonatal period. Today, we screen in the United States, there's about 81 conditions that are recommended, and this means that about 200 families get a call every day where their newborn had what's called a screen positive result. That doesn't mean they have a condition, but it means that some change happened in the laboratory that we need to follow up on. This ultimately results in about 50 newborns a day being diagnosed with one of these 81 conditions. And again, this gives us that window of opportunity to begin to intervene and to treat and to hopefully improve outcomes. So today I'm wearing a few different hats. I'm a medical geneticist, and for the last 2 decades, I've been running a research program funded by the NIH to help advance newborn screening. I'm also a mother of an individual or a son with severe combined immune deficiency. That's a long name for an immune deficiency that previously was fatal in the first year of life. SCID was the first condition to be added to nationwide screening in the United States through a federally recommended process that we'll talk a little bit about. So it's great to be here today to kind of combine my two worlds and talk to you a little bit about how I advocated for SCID newborn screening. So my job today is to give you a little bit of the basics of newborn screening, because many of you may be thinking about, why isn't Batten disease part of these newborn screening panels? You saw that wonderful list of genes that was presented. There's so many targets and so many reasons that it would be great to identify Batten disease in the very early moments after birth. So newborn screening across the world is a multi-component, multi-stakeholder system that really ideally begins with prenatal education, followed quickly by neonatal screening. Some of the screening happens in the birthing hospital, like screening for hearing loss and congenital heart disease. Others happens from a little drop of blood taken from the heel and then sent to state newborn screening laboratories across the United States. In the United States, although newborn screening is federally recommended, each state gets to decide what technology they use, what conditions they screen for, what type of diagnostic approach that they have, and then also what kind of treatment and care that the individuals who are identified get to receive. So I think of this as a perfect sort of scenario for a researcher like myself to understand more about these diseases. If we can identify diseases in the first moments after birth, and then quickly get those families and individuals into care, and then follow them throughout the lifespan. You heard a lot about natural history studies today. One of the most important handoffs in newborn screening is that handoff to a clinician, and clinicians like sitting next to me today who really guide the family into meaningful interventions. I want to emphasize that not all of the conditions that are part of newborn screening, and in fact the majority, are curable. They're all treatable. So we can make a meaningful difference in these individuals and families' lives, but we're not curing disease. We're treating it and we're intervening with it. And I want to emphasize that that's one of the misunderstandings of how does a condition get to be part of nationwide screening. You don't always have to have an FDA-approved therapy. You have to have a meaningful intervention. And for some of the neurological disorders and other disorders that we're learning about, an intervention can be an early referral to physical therapy or parent and child training for how to play with a newborn. So there's lots of ways that we can intervene and make a difference in families' lives. So it's very important to kind of think as we plan for the day that Batten diseases could be part of newborn screening, to think about these components and what do we need to do on the research side, the public health side, the clinical side, and the advocacy side to get ready, from screening to diagnosis to treatment, and then ultimately sort of making the case that there's a benefit to the early identification and early intervention in Batten disease so that it could be part of nationwide screening. A big focus for me over the last 20 years has been building these longitudinal data sets so that once we have a condition that's part of newborn screening, we can follow those individuals and their families and understand health outcomes. We want to make sure in the United States that a child born in Lincoln, Nebraska does as well as a child born in Boston, Massachusetts. We want to make sure that everybody gets screened and everybody quickly gets referred to the best clinical care practice and the best clinical care services so that the family can really realize the best possible outcome for every newborn and every individual diagnosed. As the previous speakers mentioned, this also means a lot for the family. We have cascade testing, where often a newborn screening result will clue us into what might be happening in our immediate family and in our extended family. What a wonderful opportunity to be able to address and hopefully prevent diseases. So, how do we expand newborn screening? How do we get more conditions onto the recommended uniform panel, or the RUSP as we call it, in the United States? And so newborn screening began in the 1960s with a president, John F. Kennedy, where he had an interest in intellectual disabilities and the discovery that there was a single gene called phenylketonuria, or PKU, that led to a disorder that had, if you could intervene and change the diet of the newborn, that they wouldn't have intellectual disability. So newborn screening began with one condition. And fast forward 5 decades later, and now we have over 80 that are part of the panel. Newborns used to get referred to physicians like myself, metabolic geneticists, who treat these inborn errors of metabolism, they're called. But now we're screening for many, many different types of disorders. We are screening for heart disease, so the referral to a cardiologist for surgery. We're screening for immune deficiencies, so a referral to an immunologist. We're screening for spinal muscular atrophy, so we've got neurologists who are part of the team. And so we're just seeing this wonderful expansion and use of newborn screening to treat so many different types of diseases. This has also led to thousands of discoveries in information technology, molecular biomarkers, different ways to identify diseases in the earliest stages. So how do we expand, and how do we start to develop this evidence base? One disorder, cystic fibrosis, I think is a useful case study. And so with CF, these individuals with this graph, if you can read this, in the 1960s, the average life expectancy on average was 10 years of age. In my kindergarten class, I actually had a little boy who sat next to me who in 2nd grade passed away from cystic fibrosis. I grew up in a very small town in Nebraska of 250 people, but we had a family who had cystic fibrosis, and it always interested me in genetics and sort of the foundation of diseases. But what we've learned over time with CF, because it has a very common, it's 1 in 25 Caucasians carry the variants that result in cystic fibrosis, we see it quite often. And so we have many individuals living with CF. So we've learned over the years to do a better job of managing the symptoms. And so through that, we've also learned a better way to intervene with some of those molecular scissors that you heard a little bit about. So there's some of the mutations or some of the variants that cause CF that now have a molecular treatment. So CF has evolved from something that had very early, very short life expectancy through learning how to treat and manage the disease, and now, in some cases, how to cure the disease. And now it's part of newborn screening. So it's a really useful case study to think about. At the federal level, we've got in the United States a federal advisory committee called the Advisory Committee on Heritable Disorders in Newborns and Children. And several years ago, they came up with this schema where we could have advocacy groups and clinicians and parents and families nominate a condition to be part of a federally recommended uniform screening panel. I was actually on that committee when it very first got started in the early 2000s, and I was there as a representative. At the time, I was just finishing my PhD and was part of the human genome team where we were sequencing the genome and trying to figure out the ACGTs and what they all meant. And when I got invited to apply to be part of the committee, I got to learn about all these different diseases that could be candidates for that. And one disease kind of piqued my interest. It was my son's disease. And in fact, I didn't really even tell the committee that I was a parent, because I didn't know, even though I had a son with SCID, I didn't know that it could be diagnosed in the prenatal period. So this picture is a picture of David the Bubble Boy, if you've heard of him. He was sort of famous in the 1970s. He was born, like my son, with no immune system. And they lived in Houston at the time, so the astronauts built him this bubble to live in for a while. And they were sort of trying to figure out, how do you replace an immune system when you don't have one? And this is a picture of my son, Joey. So when I was a graduate school and had my first baby, he had failure to thrive, and just by luck, we got diagnosed very early and then spent his first year of life, you can see with the little outfits, first year of life in isolation in a hospital where we did a bone marrow transplant. So this is my mom and dad actually during Joey's transplant. But Joey did well. He got an immune system that was partially recovered, so he's had some challenges over the year. But of course, being a geneticist, then I had twins. One of them is here in the audience, just listening in. And so we've learned a lot about SCID over the years. We've had our challenges. Joe's facing another transplant because his immune system was partially fixed. But we've learned more about how to do transplants over time, and his little brother was actually a complete match. So I recognize all of our struggles as families and researchers and advocates, that we sort of never go too far from the disease. But boy, have we learned a lot. Just the fact that SCID could be part of the newborn screening panel worldwide, the ability to do population-based screening and really understand about a disease. So on the left is sort of a picture or cartoon I put together of my son's maybe first 3 to 5 years of life, and all the different visits, all the different professionals, all the different teams that kind of had to keep him going. And then beyond that arrow on your right side is what SCID families have today. They're able to get a diagnosis early in life, before overwhelming infections take over, before the consequences of having an infection in your brain or having an infection in your heart sort of lead you to have limited functioning. And so I really advocate for screening for more conditions, even when we don't have a treatment, that we're going to learn so much about these diseases and maybe discover the next treatment. So for all of us, if our objective, sort of the holy grail, is to get added to the RUSP, just that sort of stamp of approval that it should be part of newborn screening, we really have to think on the research side. What research do we need to do? How do we engage families? How do we listen to families? How do we get families to be part of these efforts, preclinical and clinical trials? So newborn screening pilots are so important. And through my work over the last 2 decades, I was so lucky to be part of about 10 pilots of newborn screening for new conditions in the United States. And one that we are really excited about, that we're hoping to get onto the RUSP shortly, was a 2-year pilot of Duchenne muscular dystrophy. And so in this effort, we really worked in New York State, worked across really large hospitals, even during COVID, had to adjust our recruitment rates and, sort of how we approach things. And with Duchenne, there's not a cure. There are some treatments, but we're still developing cures. So this reminds us that we can work to add things to nationwide screening even before a cure happens. So this has been undeniably successful. Since the RUSP came on board in 2010, we've added several conditions to this nationwide panel in the United States, and that has trickled across the world, that we're able to screen for some of these disorders now, that we've touched so many lives, and we've really spurred technology development, from the ways we screen for things to the way we diagnose and treat and manage these diseases. And we've learned from families about the impact of early diagnosis and what it means to them. But can we do better? Now that we know so much about genetics and genomics, and we have all these new techniques, can we have new models? Sometimes the newborn period is too late. We could do it in fetal medicine, or we could do it prenatally. We could do it in many different ways. So I really advocate today for doing new models and new ways to think about population-based screening, where we have the overall goal of new designs and new ways to get as healthy as we can individuals and their families. So to do this, we really need to think about new models and new partnerships. And I think that's what's so cool about being at this conference, is that there's so many individuals from different walks of life, and you all have different levels of expertise that you can really bring it together and bring together sort of the best outcome for Batten disease, and thinking about the future and really developing new therapies and being able to be part of these types of screenings. So in future efforts, so we have had a lot going on. You heard a little bit about genomics and what's starting to change. Genomics is really giving us a new window into what we could be doing, not only to add new conditions to the recommended uniform panel, but to rethink conditions that have been there for a while. We now have molecular therapies for sickle cell. Sickle cell was the second condition added decades ago, and now we're actually able to do a better treatment. And so we should continue to do research on conditions, even if they're already part of newborn screening for many years. There's many studies across the United States, Australia is leading some of them, and across the world, to do genomics in the neonatal period. And so we're able to learn about all these different diseases and all these different treatments that we could have a real impact on. But with genomics, there comes sort of a challenge. It's really, I wouldn't say stressing the newborn screening system, but it's heightening the urgency. With some of the conditions that we screen for today, you know, you have weeks and months and even a few years to do intervention and to do the planning and to do, you know, what you need to do to support the family and the child. With these newer conditions like SMA, it's literally hours. With SMA, there was one study where the diagnosis to have the best outcome, and this is after a screen positive, the diagnosis had to happen by 7 days of life, and then the treatment had to happen by 20 days of life. To be able to do that type of treatment is very complex because, you know, in newborn screening, if I explained it correctly, in the United States, it's this patchwork of a state newborn screening lab interacting with clinicians. And even in Nebraska, we don't always have the clinicians to be able to treat these very complex diseases. So how do you get a referral to another state? How do you move your family? How do you get the treatment? How do you get the treatment within the first 20 days of life? That can feel really overwhelming. And so I was lucky to do, I just ended a 3-year study where we were looking at SMA implementation and what would it take to be able to sort of speed up this diagnosis and the intervention. And we really wanted to listen to parents and families. So we included parents and families with SMA across the United States and wanted to listen to them and see what would it mean to your family to get this diagnosis in just the first days and hours after birth. And then we also recruited the clinicians who would take care of these newborns and be able to not only sort of diagnose SMA, but to do the intrathecal injections that was required. I remember working for years with child neurologists on SMA, and then when the therapy became available, they all had to get OR privileges. It was something new. It was something they had never done before. So it was, you know, pretty fascinating to really watch this evolution of clinical care sort of in real time. And then we worked with the state programs, and this is the purple in the United States map are the states that we were able to recruit within the 3 years. We really wanted to get sort of a diversity from large states, small states, states that had neurologists sort of at hand and states that didn't, to really begin to build this model for the future where time is of the essence once you get that diagnosis. So there have been a lot of changes in the United States that I kind of wanted to highlight in 2025, there have been several committees that have been eliminated and disbanded that have impacted newborn screening and newborn screening research. But I think these challenges that we're undergoing have really sparked a new wave of advocacy. And it sort of could be a better time, but maybe isn't a better time for Batten disease to be part of the newborn screening story, because we're hearing from so many people that really saw newborn screening as the promise and really want to fulfill that promise. And so we have, from the American Academy of Pediatrics to many, many different other organizations who weren't usually as involved in newborn screening, really beginning to speak up. Advocates like yourselves, state newborn screening programs, everybody's really at the table and advocating for advancing newborn screening and getting some of these committees and some of the important research dollars back to the table. There was also an advisory that came out from the national academies on how to strengthen newborn screening in the United States. And I think it's informative for the rest of the world. It's several hundred pages long, but it gives us some really key things to think about over the next decade or two on how we can really revolutionize newborn screening to meet the needs of all families. So we've got a lot of keys to continued success and even how to accelerate these efforts. And you all can play a really important role. So I hope that I've given you a good tour today of what's going on in newborn screening and excited you to get involved a little bit. If you want to hear more, I still have a podcast that's up where we hear from families like yourselves, from researchers and clinicians and state newborn screening programs that are really working to use everything we're learning about genetics and genomics to advance newborn screening. Thank you.
Yes, we have some time for questions if anyone has any.
I have a question. Hi, my name's Ned Timmerman. I'm father of Jack, CLN1. So all of our babies are IVF babies. Has there been any consideration to expanding the push? Because Jamie and I were obviously screened prior to our IVF treatments, but obviously not a comprehensive screening that would include Batten. Is there any thought or push towards those who go through IVF to be able to make informed choices based on their carrier status?
That is so I feel that disappointment of like, why weren't we screened for this before? And I think that just has to do with our panels. We often do carrier screening panels, and it looks at a set number of genes. And so someone has to make that decision of how many genes go on this panel, and there has to be a cutoff. And so I think, unfortunately, Batten disease is sometimes cut off of that panel. And it's very frustrating, I think, because a lot of people are like, well, we'd love to have that information. So it's not perfect, but I think, it could be helpful for, I always say I'm a big pro of genetic testing. I may be very biased, but I think sometimes bigger panels can be super helpful. So maybe if someone is considering going through carrier screening, asking about the biggest panel you have possible if you're open to getting more results. Some people feel like more information is better, and I think if you're in that position, it may be helpful to really just get the biggest screening possible, but even then things are still left out, which can be disappointing.
Sure. I think from my perspective, it was just an education standpoint of what could we even ask for? Was never really presented or talked about. It's just like, okay, we're gonna do a screening. It's like, okay, great, but I had no idea what it was gonna. So just if we can do anything at all to better educate people going forward, so that they will know what their options are and how much you could request, because we just had no idea.
Hard. Thank you for
Sure.
raising that issue. I think one of the things we know too is that the more people that get sequenced And the more that we're able to share everybody's genome, that we're going to do a better job of interpreting it. What did this change mean? But we also need to look at those functional tests. Yes, you had a change. As you heard, they talked about those variants of unknown significance. But what did that change do? Did it change the protein? Is it going to change something that's important to myself, my wife, and my family? And I think one thing I want to point out is that we don't have diversity in our DNA databases. And so even as we move in the newborn screening period from sort of chemical tests to DNA-based tests, we may get an answer for folks that maybe have the background that you and I do, of maybe European. We won't get the right answer for individuals from other backgrounds. And that's a real crisis. And so I think one of the things we can all advocate for is data sharing with protections, with informed consent, but make sure that, data can go into databases so we all benefit and so that we benefit from your and your wife's experience.
Sure.
Thank you for sharing.
Thank you.
Hi, Ryan Anstad. I have a daughter with CLN3, and she's 10. I would like to better understand why we can't test all 20,000 genes. And if we can, maybe in the future, how do we get there?
That's a really good question. So when we do sequencing, we will often look, like they'll run the code for all 20,000 genes, right? It's sitting there. But that's an immense amount of data to work your way through. And so how we find genetic variants, it relies really heavily on the clinical information that your provider puts into the system. So when we fill out a request for genetic testing, it says, why are you ordering this testing? And you'll say, the patient has XYZ symptoms. And that puts all sorts of filters on the sequencing. And so the report that comes back really focuses in on genes that we know to be associated with the symptoms that your provider put in. And so it's less a question of, we do sequence all of that data. The question is, how did you process it? And so we haven't quite figured out how to process all of it at once. Some of it has to do with just the immense amount of data that is. And I'm sure that we're moving somewhat closer and closer to that as we go. But the other parts are that some tests don't cover the introns, which are the parts that are in between the parts that normally get cut out. And we're learning more and more about that space and knowing that that's actually really important, even though it doesn't turn directly into proteins. So it's really, we're learning more and more both about the genetics and then also about the technologies that we can use to process that data. And so maybe one day, but we're working on it.
And I also want to add, insurance does not like to pay. I know we brought up insurance already. Insurance does not like to pay to test everything. So I can think, if vision loss is the only symptom that someone has at the time, it's going to be pretty hard to get insurance to pay for whole exome or whole genome sequencing. Some insurances are pretty particular about when they'll pay for that. And something else I just want to comment on, because it's the gene panel, and you mentioned CLN3. The most common variant for CLN3 disease is a deletion of exons 8 and 9. So there's 2 exons missing. Our whole exome and whole genome sequencing, there's limitations in what's done, and they miss variants. And that specific variant in CLN3 disease is not detectable on most exomes and genomes, which is, from my perspective, has been very frustrating, and I've been trying to get the labs to be able to test it. But so there are probably a lot of people who have CLN3 disease, and their testing of all 20,000 genes actually comes back negative, and it misses that variant. So there are definitely pros and cons to testing everything all at once, too, because it can miss things that maybe more targeted single gene testing or small panels could detect.
That line, I think one thing that we're hoping that if we're able to sequence the genome of every newborn and we ask the questions we know what to do with in the newborn period, but then we give that sequence to the parents, There's some studies that are looking at age-based reinterpretation of that genome sequence when there's about 60 hereditary pediatric cancers that we could identify through a newborn sequence, but we wouldn't need the information till the baby's maybe 2 or 3 or 4. So could we do an age-based sort of relook at the genome? So there's a lot of people sort of thinking about new ways to do this, and we don't understand what every one of the 20,000 genes do, and we don't understand what diseases they're part of. But with individuals like yours and people in the audience being part of research and advocating for that, maybe we'll get there a little bit quicker. So thank you.
I have a question around the CLN2 newborn screening, sort of a two-pronged question. So we know this is the only subtype of Batten disease that has a regulatory approved therapy at the moment, so it lends itself very nicely. It fulfills most of the criteria for it to be on the newborn screening, because we know earlier the intervention, the better the outcome for the child. First question is, what do you know around the Screen Plus study that's happening right now in New York? That is where CLN2 is one of the pilot conditions being tested there. And secondly, what can families and advocate bodies like us be doing on a really practical level to be advocating and getting that on the radar for the RUSP?
Dr. Wasserstein's study, Screen Plus, is so wonderful. And, you know, we worked with her for years kind of building a longitudinal database for LSDs so that we could understand once they're screened, how are the kids doing. So I think it's a huge step that it's part of that. But I think all of the genes on the gene list, what I would do is advocate for anybody doing genomics in the newborn period to look for those genes and look for the variants that they just listed that are common, that we know about, that pop up. And, you know, now that we have our federal advisory committee sort of disbanded in the United States, the best place to go is where the numbers are. New York, California, Florida. Florida just started a wonderful Sunshine Genetics program where they're going to offer sequencing to every newborn. It would be calling that lab and having them look at the CLN genes, doing it kind of a little bit strategically, back of the envelope, you know, going to the biggest programs, Genome England. Why aren't you including Batten diseases? Are you going to include it in your next round? You just saw Guardian moved from a few hundred genes to several hundred, you know, over 500, you know, get on their list. It's sort of back to the grassroots of, can we do this, you know, and get into where the most babies are born. And then you'll see kind of this cascading effect, because I do think that, you know, my former organization, the American College of Medical Genetics and Genomics, we do evidence-based reviews that kind of led to the RUSP. I think they're going to step in and do something similar while this committee's on sort of a hiatus, and hopefully it will come back. But I think that there can be this sort of back of the envelope. And if things are, again, you know, if you remember adrenal leukodystrophy, there's no FDA-approved treatment, but it's on the RUSP because they approved an intervention, you know, sort of, and we always heard when I was on the committee, just knowing for the family, just knowing that their newborn was at risk for this disease made a difference to them. So I think it's just going back a little bit to the grassroots, and that's where I was saying we're hearing from so many new voices, right? Let's do it the old-fashioned way with program after program after program, because even if something's on the RUSP, you know, Nebraska hasn't adopted several conditions that are on the RUSP, and nationwide, I think there's only one state that tests for everything that's on the recommended panel. So it still takes time, but as we all know, we don't have time. And so really kind of thinking about where can we have the biggest hit is what I would recommend. And I'd be happy to help if there's anything I can do.
Hello. So one of the things that was interesting, I think you kind of pointed out, is looking at how some diseases start with this treatment, right? And then over time, it gets better and better, and you're seeing the increased life expectancy. And I'm wondering if anybody's looked kind of more of like a global perspective of like when we can recognize this early, this is how the intervention, that the timeline of interventions improves for any disease, as like a justification for implementing newborn screening kind of more like for all diseases, of course Batten's, but has anyone kind of looked at that? Or even, you know, you brought up like PT, OT speech. I definitely think my daughter happened to be in those since she was almost a newborn, and I have no doubt that those played a positive role in her life, even though we didn't know she had Batten's yet. And how do we find a way to show that those like those types of interventions still matter and count when we want to get this disease on the panel? Because I don't think they do to the systems in place, you know? Does that make sense?
It totally makes sense, and I love that you brought that up, because I felt like that all along the way. You know, even when I was on the committee, and you know, just hearing from families where, you know, we don't know how to even treat autism early, or intellectual disability, or some hint of a disease. Can't we just know? Can't we just plan our lives better and support our families better? So I'm a really strong advocate of that. I think when we put in sort of the evidence-based approach to the recommended uniform panel, we got into a lot of how does a lab test work and how fast can the state do it? And we lost the families. We lost the really health outcomes part of it. But I think this swing back and sort of this pause in the Federal Advisory Committee gives us the opportunity to bring that voice back, because you're hearing that. You're seeing with early intervention, birth to 3, you're seeing those early touches make a huge difference. And so I think we look at support from our clinical psychologists, from our early interventionists, from our parents like you, who know that if I had more education or more support from day one, would my newborn and child have done better? And so I think we just have to keep bringing up that voice. I don't think that you have to check the box of having an FDA screening test, cleared screening test, or an FDA-approved treatment to come to those advisory meetings and to tell your story, and that would have made a difference. Because we're learning so much more about how to help an individual get to their full potential by early intervention.
Yeah.
And you lose those opportunity day after day that you wait for the perfect treatment, when if you could intervene, it would really make a difference. And again, I think adrenoleukodystrophy got added without a treatment. So I use that as, you know, sort of my touch point, you know, that happened, and that it's because, you know, we were able to convince enough people to vote for it. So I think your voice really matters.
Okay. And the best way, like, for us to come do that, to advocate for that, like, how do we get these stories out?
I think there's several great national groups that have sort of developed. The Every Life Foundation, the National Organization of Rare Disorders, they have a lot of parent training and opportunities for parent voices, expecting health. You know, I would be happy to connect with you after, and with anybody, to sort of get you involved in some of those efforts. And I think it could be as much as like doing a podcast and telling your story, and how do you touch people, and how do you get your story out, and, you know, sort of your perspective out, so that we don't forget about it when we're thinking about the ACGTs and molecular scissors.
Thank you.
Okay. So I have 2 questions. One of them is when the environment is more conducive to having advisory panels again, is there going to be a push to have a nationwide mandate for newborn screening? And my second question, so I have 2 kids with CLN3. I know a lot of families who have multiple kids with CLN3. Is anyone looking at the possibility that, even though there's technically a 1 in 4 chance, that's a little bit weighted, that, you know, that affected gene maybe like muscles its way into our kids? I'm just curious about that. So that's my question.
Well, that is a a very good point to bring up. Why are we seeing more families that have more than a 1 in 4 chance of this happening? And I think it comes down to every child has their own independent 1 in 4 chance. So it doesn't matter what happened before, and it doesn't matter what happens after. And I'm sure there are families out there where both parents are carriers and none of their children have it, but we don't know about them because they don't come to our attention because their children aren't diagnosed with any form of Batten disease. So I think it's more of a selection bias, I think would be my gut reaction. But I would never say never in genetics. I think there's always new things that we're learning, and I think it'd be worth it to look into to really answer that question. But my gut reaction is that it's probably more of a sampling bias because we don't know about the people who are like unaffected or carriers, because there's probably people out there who have a bigger proportion of that than maybe a child who's affected.
Old enough that when I studied genetics just down the street in my undergrad, that we used to call 98% of the genome junk DNA, and now we use it to invent new drugs. It's amazing. So you could be right. You could have the next theory. So, like you said, never say never in genetics, but sometimes it does feel like that something's happening. We learn so much about, how genes interact with each other. I think there's this, public health system in the United States, and then there's federal recommendations and something we're all learning about called states' rights. So we never really ever have federal mandates, but we do have ways federally to get states to do certain things. We can do things like tie it to Title V funding or Medicaid funding or school-based funding. So some states do a better job honestly with implementing newborn screening. And again, it's not just the screen. It's the quick diagnosis to care. It's the birth to 3. It's the making sure they're in the right school program, making sure they have the best outcomes. We don't have a national system to track health outcomes in the United States. We don't know how kids like with SCID are doing. I know because I'm involved in the community, but we have no national database to look at health outcomes, and that's a real problem because we don't know when we have issues and we don't know when we need to jump in. And in some states, about a third of them, you get a newborn screen diagnosis, you get into birth to 3. You've got somebody knocking on your door teaching you how to play with a newborn that might have muscular dystrophy. That's huge. And so I think we really need to think about new ways to use those federal encouragements as state mandates if we can. And then also with testing your 20,000 genes, we're not going to be able to do state-by-state newborn screening anymore. I'm a big proponent of regionalization or nationalization of testing. We already do that. Many states don't. In Nebraska, the dry blood spots from Nebraska go to Pennsylvania. They're tested in a lab in Pennsylvania. We do have no newborn screening lab here, and it works perfectly. And so we're able to do that and take advantage of the technologies that are being invented somewhere else. So I think it's a new sort of day to think about new approaches.
Okay, well, I don't know about you, but I can hear all this fun in the lobby out there, and I feel like I'm missing out. So it's after 5. Thank you so much. Will you join me in thanking Margaret, Alaina, and Dr. Amy on our panel? Thank you so much. It's fabulous presentations, and this is going to be a really, really valuable tool to have on our website as a resource as well. So thank you, ladies, very much.